My name is Maarten van Elst. I'm your moderator for this evening. I'm a nurse practitioner of the University Medical Center in Utrecht of the Netherlands. But on behalf of the European Association of Urology Nurses, I welcome you for this webinar about prostate cancer and the shared decision making in prostate cancer. I have a little presentation myself. I have no further disclosures to report. To mention is the webinar is accredited with 1 point. Therefore, you need afterwards fill in a questionnaire, which sent by you by email after this webinar. Shared decision making. Shared decision making is nowadays a norm in cancer patient care, but we have to remind ourselves of what it means and do it communicate appropriately to allow patients to make a decision. Individualized information is needed to be able to make a choice of treatment. This webinar will help you to rethink shared decision making in prostate cancer. We also have some learning objectives to improve your knowledge of effective shared decision making in the clinical practice, to better understand how to use individualized risk assessment tools in treatment of prostate cancer, and to be more aware of the perspective of patient in shared decision making. We have a variety on the speakers this evening, and it's for the process the utmost to have used the button for the question and answer for all the questions you have, and we have time for and some opportunities left after the 3 presentations to have room for those questions. The presenters, the speakers, we will just directly start with Ellen. Ellen Engelhardt is a researcher of the Netherlands Cancer Institute. After that, John Dowling, a man from the Institute Uro-oncology, is an institute for prostate cancer patients with a voice for other prostate patients. And after that, Corinne Tillier, also a nurse practitioner from the Netherlands Cancer Institute, will tell you something about shared decision making also. Ellen, it's for you the time to start with your presentation.
Yes, thank you so much. I will share my screen now. Okay, thank you so much, Maarten, for the introduction. And also thank you so much to everyone for the invitation. It's a pleasure to be able to talk a little bit about shared decision making today. This first talk will be a brief introduction. As Maarten already mentioned, I'm a postdoctoral researcher. The focus of my research is mainly on the development, evaluation, and the implementation of tools to support clinical decision making. I have no conflicts of interest to declare. This first talk will give you a very brief overview of shared decision making. I mean, I could talk about this for a long time, but we only have 15 minutes, so I'll keep it very brief to the essential aspects. But I will also incorporate some tips to help you apply shared decision making during your own consultations, hopefully, to be able to incorporate the patient perspective more effectively in decision making. I think it's good to point out my own field of research is mainly breast cancer, so I will also share some examples that are outside of the prostate cancer context, but I do believe that they will help illustrate the points I'm still trying to make, and you can imagine what that would look like for you in the prostate cancer setting. But let's start at the beginning. For medical decision making over the last several decades, there has been a paradigm shift, whereas in the olden days, decision making was much more paternalistic. So the clinician shared the information about the diagnosis and the recommended treatment. The patient agreed or declined that treatment plan. It moved more towards informed medical decision making, but yet again, it's very unidirectional. So the clinician was a fountain of information and the patient made the decision on his or her own. In the shared decision-making approach, the central aspect is that the clinician, health professional, is an expert on the biomedical side of things, on the treatment and the diagnosis, but the patient also has expertise on her own life, what's important. And by combining these two aspects, so the biomedical and patient's values and preferences, you're able to arrive at an informed decision that really matches what is important for a patient. And that is not only ethically, one of the better options for decision-making, but it also ensures that patients are satisfied with the decision and feel a sense of ownership in decision-making. So Glenn Elwin, who is one of the main and best known researchers in the field of shared decision-making, stated that the aim of shared decision-making is to help your patient develop an informed preference. So the key aspects in this process is to make sure that your patient is aware that there is a choice and that partnership is key. The patient's input is just as important, if not more important in some cases. And without that input, it's not possible to make an informed decision that suits their situation. But before I go into the practical aspects, so, what does it look like? What do you have to do when you want to adopt a shared decision-making approach? First look at, does it have any added benefits? I've already mentioned that from an ethical perspective, shared decision-making is, the preferred approach. It's the patient's body and nothing happens to it without their input, their consent. So it's the right thing to do. And that's one of the strongest arguments that you can find in the literature, about why you should adopt a shared decision-making approach. But you can also look at, does it also provide better outcomes, not only from an ethical perspective and, it's the right thing to do, but also clinical outcomes, for example. I have to say that if we look at the literature, what we find is that it's very difficult to measure. It's very difficult to conduct, for example, a very, traditional randomized controlled trial, for example. Shared decision-making doesn't exist in a vacuum. There are a lot of other processes that can impact it, that you're not able to just turn off to just look at what is the effect of the decision-making, of adopting the shared decision-making approach. But what we do know from the literature up to now is that adopting a shared decision-making approach, you see that patients are much more satisfied with the final decision, with the treatment and the whole process. You find that patients are less anxious and have less fear. There is also less undesired variation. So specifically with regards to treatment, and also with regards to information. I will come back to that point a little later in the presentation. So there's more uniformity. So it doesn't matter which clinic you visit or which healthcare professional you see, everyone has a minimum standard of information to make sure they're able to make an informed decision. You also see that there is more equality. So specific patient groups that perhaps might be less involved traditionally in decision-making, for example, people with lower educational status or with a low health literacy. When you adopt a shared decision-making approach, it facilitates greater participation by these groups. You're better able to understand, their motivations and have them be involved in decision-making. There are also some indications that shared decision-making can improve treatment compliance. Patients feel more ownership of, the decision as they actively participated in it, and that can help people adhere to the treatment plan much better. But these are indications, so it's a lot more research is needed to investigate this better. The final point is often a concern for clinicians. If you adopt a shared decision-making approach, does that mean that you need more time for your consultations? And that often isn't something that's easily accommodated. But the indications we have from the literature is that consultations do not take more time when you apply shared decision-making than if you were not applying it. And next question, and a very difficult question, is when should you apply shared decision-making? Should you just apply to all consultations, or is it best suited for specific contexts? I can say there is a lot of debate on this topic and a lot of discussion. So maybe that's an interesting point for discussion after these lectures. But in general, what we can say is, irrespective of the type of decision, patients always need to be informed in a balanced way. And we should always try as clinicians to stimulate participation, patient participation in decision-making. But formally adopting a shared decision-making approach is not necessary in every situation. In the literature, two types of decision types are distinguished, and these decision types determine the role distribution between patients and clinicians in the decision-making process. So you either have expert decisions or preference-sensitive decisions. When we speak of an expert decision, then there is medical certainty. So it's clear which option is best. And it's also clear that that best option has more benefits than harms. So it's clear that these benefits outweigh any harms that the treatment could cause. The focus of the consultation is then on implementation. So how do you get the best results so patients can adhere to the treatment plan proposed? And here again, even though it's clear that there is a best option, it's very important to also leave room for the patient, because that it might be from the literature the best option in specific situations. For example, it might not be. So patient participation is also very important, even when you're dealing with a so-called expert decision. Now, the patient preference-sensitive decisions, so these are the decisions that are generally deemed more suited or where a shared decision-making approach is essential. In this case, medically, there isn't a clear best option. So there either is scientific uncertainty about, is the treatment effective enough, for example, in specific subgroups, or the treatment is effective, but it has some significant side effects, for example, and then a subjective trade-off needs to be made that incorporates the patient's value to determine, do the benefits, the expected benefits, outweigh these side effects that can significantly impact the patient's quality of life, for example. In these cases, the focus of the clinical encounter should be on weighing up these pros and cons, so making this subjective trade-off. And any kind of steerings is undesirable. So in these cases, the essence is what is important for the patient and how do the pros and cons weigh up. Okay, so I've talked a lot about, shared decision-making very abstractly and why you should do it and when you should do it, but what does it actually look like practically? I have to point out there are many models of shared decision-making that you can find in the literature. In this presentation, I used a model described by Stiglbaut and colleagues, but there are other models. Generally, they do overlap, so it's not very different. It's just different labels are used or a different division in steps, for example. But the Stiglbaut model consists of 4 steps. First of all, creating choice awareness. The second step is about informing patients about all relevant options. The third step is the weighing up of the pros and cons. And the final step is where it's determined which role, so what role the patient would like to play in the decision-making process, and the final decision is made. I'll go through each of these steps and give you some tips and stuff we have seen from our own research and others' work that is, very important to keep in mind to effectively implement the shared decision-making in your own clinical practice. So for the first step, creating choice awareness, it's very important to be clear and explicit. You need to make sure that the patient is aware that there is a choice to be made. And that from a medical perspective, there is no best option, for example, when we're talking about a preference-sensitive decision, and that the patient's considerations and preferences are very important to make this decision. So the discussion, the exchange of information between you and your patient it's very important to determine which treatment is best for, this specific patient. Timing is crucial. It's very important to do this at the beginning of the consultation. Generally, you listen differently to information that you're receiving if you know that you will need to do something with it. So you can activate people to participate in decision-making if it's clear from the onset for them that they have a choice to make and that their opinions and considerations are very important for this. So I can imagine that you're thinking, well, that's simple, that's very straightforward, and that everyone should be aware of that, and that's easy to do. With some colleagues a few years ago, we looked into this. We examined consultations about rectal and breast cancer treatment, and we looked at whether choice awareness was created. What we saw is that in 30% of those consultations, no explicit reason was given for why we were having this consultation. In 35% of consultations, it seems like this decision had already been made and the patient was only there to be informed about, what was going to happen. And in only 3% of the consultations, an explicit reference was made that the reason for the consultation was making a treatment decision. And all of the consultations we looked at were preference-sensitive decisions. So technically, in all of them, decision-making was one of the key aims of the consultation. The second step, so if we look at information provision, it's important to discuss all relevant options, and in some cases, also the do nothing, or for example, active surveillance option can also be relevant. So it's important to explicitly mention that. So a key here is to make sure that the information is balanced. So pay equal attention to the expected benefits of the treatments as to the possible side effects. People need to be made aware of both aspects before they give their opinion on whether or not they think treatment is worthwhile or whether they have a preference for one of the different options that might be available. It's also important to have an information standard within the team within your team, for example, to avoid unwanted variation. So each patient, no matter which clinician they see, should have the same basic information to be able to make the decision. This doesn't always happen. So just to illustrate this, an example from the breast cancer setting. So we examined consultations on decision-making about chemotherapy for breast cancer. It's not important, the details. So the key point was that in this graph, you can see all of the side effects as an example that were mentioned in those consultations at least 10 times. The first thing, it doesn't really matter which ones were mentioned, but the first thing that you can notice, well, there's quite a list there of side effects, which isn't surprising when considering chemotherapy. But what did surprise us was that not a single side effect was mentioned in all consultations. So that suggests that there is a lot of variation, not only between clinicians, but also within clinicians. And you do want to make sure that it doesn't matter who the patient sees, they get the right amount of information to be able to weigh their options and to develop an informed treatment preference. And it can be very difficult. I mean, it's a very difficult situation, and emotionally, having just received a diagnosis, for example, and being inundated with lots of information, it can be quite difficult to convey. There have been many tools developed to support decision-making, these so-called decision support tools. An example of such tools is a patient decision aid. Generally, these are online tools that provide information about the disease itself and the treatment options. They often contain values clarification exercises and also examples of patient experiences. In these pictures, these are screen grabs from a Dutch prostate cancer decision aid. On the left-hand side, you can see just an impression of the information they provide about prostate cancer, what it is, and all the treatment options. On the right-hand side, you can see an example of a values clarification exercise. These are statements, and you have the little blue balls. You can direct them towards the side that best reflects your preference. And this can help patients think about what is important for me. So what what gives me, which treatment option is the one that I'm leaning towards. Another type of tool that can also support decision-making are risk prediction models, which provide personalized risk information, and they can help patients and clinicians weigh their options. So on the screen, you can see an example of a prediction model. So this is a prediction model, predicts prostate, developed in the UK. And these tools provide information about, your expected survival, but in this case, they also provide information about potential harms, how likely they are to occur, and the severity of them. In the final talk of this webinar, Corinne and I will discuss this, and we will get back about, how important it is when you want to use these tools to communicate risks appropriately. And the final point for step 2 is to always check whether your patients understood the information. And the best way is to ask them to tell you back what they heard, not as an exam to see whether they were listening, but to make sure that they understood things, that, what you meant to tell them. The third step is weighing up the pros and cons. Important, take your time to hear about the patient's considerations and how he or she weighs their options. And also important here is to embed, to make sure that your decision-making becomes part of the clinical workflow and not just part of your clinical consultation, but also, for example, taken into account in the tumor board meetings. An example from the esophageal cancer context, which they incorporated shared decision-making in their whole workflow. In the graphs, you can see the 4 steps of which their clinical workflow for patients who come in for the diagnosis esophageal cancer. And they just incorporated the different steps into the different aspects of their clinical workflow. So in the tumor board meeting, for example, by getting information in the first meeting about patients' insights, their goals, they can also incorporate that when thinking with colleagues about which treatment options might be relevant or more suitable for to present to the patient. So this can also really impact and make it easier to be able to apply shared decision-making in your own clinical consultations with your patients. The final step is decision-making. So it's key to ask patients which role they would like to play. And I can imagine that perhaps it seems strange to ask them at the end, but you need to know what you're deciding about and whether you feel capable to be able to truly participate in making the final decision. So it's advised to ask this at the end and not at the beginning of the consultation. And it's important to keep in mind, even if your patient is not able to or willing to really make the final decision, shared decision-making is still possible. I think you might all be familiar with this quote. It's not the destination, it's the journey. For shared decision-making, it's not about who decides, it's about the process and the incorporation of the patient's perspective. I'm a little bit over time, apologies for that, but I want to thank you for your attention thus far. And please remember, if you have any questions, just put them in the Q&A for the end of the webinar.
Thank you very much, Ellen, for this nice presentation. We now heard how it should be, the process of shared decision making. For now, we're gonna learn and see how it's come over to the patient from a patient kind of view. And then later on, by Corinne, we will put this in clinical practice. So for now, John, it's up to you to tell us about patient's perspective. Okay, so thank you very much for inviting me to talk to you this evening. I have no disclosures or conflicts of interest. I hope I can give you some idea of the patient viewpoint. I hope I'm not just being contentious at times, but I perhaps won't agree with everything that Ellen outlined in
terms of the difference between our desires, our aims, and how these materialize in practice. Yeah. Okay. Next slide, please. First of all, before we get into the meat of it, I just wanted to say a word about my own sort of prostate cancer situation. I'm 20 years since I've been diagnosed with prostate cancer. I didn't have any, what would you call it, shared decision making. I'll come back to that later. I had radiotherapy, and everything was fine for a while. For 4 years afterwards, my PSA had gone down to almost undetectable levels, and then my PSA started to climb, and eventually I agreed with my radiation oncologist that I would take androgen deprivation therapy. I was on that for about 3 years before I met a urologist at a conference who asked me, had I considered intermittent androgen deprivation therapy. I'd never heard of it. He sent me some papers. I then decided I would adopt that. I told my oncologist that that was what my preferred, I had already stopped taking the medications, and he said he didn't support that intermittent approach. So I said, well, that's all right. I'll still come and see you. And a year later, he had a whole cohort of people who were on intermittent androgen deprivation. And we had a discussion as to what level of PSA would be sufficient for me to cease taking the medication, and then at what point would my PSA be such that I would go back on medication. So I did that for approximately 13 years, and then I stopped doing it altogether. Again, so the question for many patients is not that anybody's against shared decision making, but is it actually genuine shared decision making, or is it all motherhood and apple pie? And do healthcare professionals practice what they preach? How many consultations are conducted in a language which the patient finds that they are actually being involved in a process where their input is actually part of the decision making? Does the healthcare professional ask the patient, what do you want to do? Or how do you see your situation now? Or what do you see as your options? I would have to say that in my experience in talking to patients, both in peer-to-peer and in conferences and so on, the practice tends to be somewhat different from the aspirations, I think, as Ellen elegantly outlined. Yes, shared decision-making does exist. I think despite what my colleagues, many would believe, I think it would be churlish for patient interest to claim that it wasn't there. In my own personal experience, it has been there. And that the question may arise is, well, if everybody favors it, it must be there. Well, not necessarily. In my country, about 40% of prostate cancer patients are diagnosed in private practice. And these do not tend to be multidisciplinary teams. And there is a question mark over whether the kind of dispassionate presentation of options is in fact real. the other question then is, does the patient really want to be involved in the decision making? Bear in mind, when the patient is given a diagnosis, he's usually bamboozled. He's fearful. He is at sea, and asking him to participate in a decision-making process, however you do so, is not exactly always something that they're attuned to doing. However, I fully accept the points that Ellen made, that it is to the benefit of the patient and to the healthcare professional that the patient would have some input, that they be encouraged to do so. But we have to face some reality in that many patients do not have a sufficient medical literacy to make a very impactful contribution to shared decision making. But that scene is changing. I think over the last 20 years, I've seen in my time as a patient a remarkable development in terms of patient training, and not just in prostate cancer, but across cancers generally. UPATI, national platforms who run their own programs, and our own specialist organizations who run our own training programs that are disease specific. They weren't there 20 years ago, they are now, but they will take some time to prove their benefit. As we know, one of the features about prostate cancer is, unlike perhaps every cancer, you do have the time usually to weigh up the treatment options, but they are very many. It's a plethora. You have different forms of surgery. You have open, robotic. There are still some people doing laparoscopic. You have different forms of radiotherapy. You have brachytherapy, you have external beam. You have different forms of brachytherapy. You have different forms of external beam, and so it goes on. The question of active surveillance is going to be, and is already, a major factor in prostate cancer. The proportion in some countries of men who are considered low risk who are undertaking active surveillance, which is not a do nothing, it's an active program as it specifies. And I think this will be an increasing proportion as screening for prostate cancer improves, and as men are then who are at risk are diagnosed earlier. I think we will have even more, a greater number of men going on to active surveillance. Next slide, please. In shared decision making, there is a huge difference between countries. If the little diagrams to the right hand side, if the block out on its own were to be considered as Iceland, Ireland, and the UK, the further east you go, the shared decision making, or the evidence for shared decision making in prostate cancer, tends to not be as strong. The further south you go, similarly, the decision making, shared decision making, tends to be less prominent. In Scandinavia, it is almost de rigueur. In Ireland, it depends whether you're in the public service or public hospitals or in the private domain. So the benefit of shared decision making, I don't want to repeat what Ellen has already taken us through. I totally concur. The benefits are important, and I think they're not always seen by the patient, that they get a tangible benefit, because how do you compare with not having had a shared decision making with a shared? So it is a difficult thing to sell. As Ellen pointed out, you cannot study this very easily because of the nature of the beast. Next slide, please. So does it really exist? Yes, it does. And it's a growing. Shared decision making is maybe not as widespread as perhaps the EAUN would like, and as most patient organizations would like. If you could just tap the keyboard again. But the one thing I would like to refer to is that it does change the power relationship. The healthcare professional has most of the power, but he has to share it with the patient, because the healthcare professional has the expertise, the skill, and the control of the delivery of the actual treatment. However, patient has the prostate, so it has to be. If you're going to have an ideal outcome, you have to have a combination of the two. I've already referred to the single specialist. I think from a patient point of view and from a patient organization point of view, we believe that prostate cancer should be provided in centers with a reasonable volume of throughput, multidisciplinary teams, and many things are possible in that environment, which will not be able to be delivered in a single practitioner scenario. Next slide, please. I mentioned the informed patient. A lot is being done, but I think both of us have a problem, the patients and the healthcare professionals. Any professional body tends to change very slowly over time, and I think that's a situation that we have with the shared decision making. However, as time progresses, I think we will resolve the matter. That I would like to make the point that clinical patient surveys about satisfaction and shared decision making, they indicate a benign trend. But Europa UOMO has conducted one and now two. We've just closed our second study, where we've discovered that there's a big difference between the kind of responses that patients will make in a clinical setting when they're face to face with the clinician, as to how they will answer the same question in the privacy of their own home. Sometimes they give the answer that they think the listener wants to hear, or that's the suspicion. Next slide, please. So in summary, you have a situation where a lot has happened over the last 20 years, a lot more yet to be done, but I think there are good grounds for optimism. And I just would make the point that when you have your prostate patient, just remember, with every prostate comes a free brain. Thank you very much.
John, thank you very much for your insight in the patient perspective. Of all the 70 participants, there are no questions for you right now, but I have some, so I will keep them for later on. Right now, I would like to give Corinne the moment to put shared decision making in clinical practice, daily practice by healthcare professionals.
Thank you very much. Well, we heard about the shared decision making in general, and we heard about the patient, what patients, the point of view, the perspective of patients about shared decision making. But what I see in the practice, and I suppose that you all the participants, you see the same, that the patient nowadays, they are interested about what is going to happen to them personally, individually, and not what is going to happen to the neighbor in case of a treatment. So the question is, can we give some individual information to the patient? So I'm going to try to give you the information. And Ellen, first you are going to say something about the first slides.
Yes, thank you, Corinne. Yeah, so as Corinne mentioned, it can be useful for people to not only know about averages, so what happens on average, but to get an indication of what their personalized probabilities are, what is likely to happen in their situation. But why would you communicate probabilities? Corinne, if you can just click and just show all of the bullet points, that's fine, if that works. Yeah, so as I mentioned already in the first presentation, and I also think John alluded to this, there is a paradigm shift towards greater patient involvement, so shared decision making, and especially when there are choices that need to be made, when there is no best option, it can help clinicians, but as well patients, if you have probabilities, so personalized information about I'm not quite sure, but my screen just went black, but I'm hoping that everyone can still see the presentation. It can help if you have some personalized information about, what's likely to be the outcome in a specific case, to weigh the pros and cons and to determine for yourself, do you really feel that the expected benefit outweighs the harms and, the impact that these harms can have on your quality of life. So using this type of information can really help stimulate patients to make more informed decisions and develop more informed preferences that can support and guide decision making. The next slide, Corinne. So in this final presentation, first of all, Corinne will give you a very exciting, I think, example from the prostate cancer context, in which individual risk prediction is used to support decision-making. And to end the presentation, I will give you a snapshot of the basics of risk communication. So if you are going to communicate probabilities, it's important to do so effectively if they are to be of added benefits and not cause, for example, additional confusion. And at the end, there is room for questions, but if you have questions in between, please feel free to put them in the Q&A box so we can address them. But the screen is yours.
Thank you. Thank you. So I'm going to give you some example from the practice. As you understood from patients, from John, we know that in localized prostate cancer, patients have several options, and it's not easy for the patient to choose. So I'm not going to repeat all the options because I suppose you know that. But the question is, for patient, for example, for patient with a low risk of prostate cancer, a Gleason score 6, for example, then you see that patients are doubting about active surveillance. They prefer to be treated, and usually they said, well, take it off, I want the prostatectomy. But as you know, prostatectomy has some side effects were not such as incontinence. So when the patient are doubting about the option about active surveillance or active treatment, then I show a model who is from the Memorial Sloan Kettering Cancer Center, and you see the link on the slide. And well, on this tool, I do it with the patient. Then I put all the comorbidities, heart disease, pulmonary disease, etc. The age, the stage of the cancer, the PSA, the Gleason score. So I'm doing, again, I'm doing with the patient together. And I give you an example of one of our patients. I call him Mr. Smith, sorry. He's 60 years old. He has a CD1C N0MX prostate cancer. In one of the 10 biopsy, a Gleason score 6. He has a PSA of 8.7 almost. Prostate volume is okay. Well, it's a little bit big, but it's okay, 60 cc. It doesn't have any comorbidity, and it quit smoking a few years ago, well, 30 years ago. It's a lot, but he has smoked a lot, more than 100 cigarettes in his life. And then you see in the tool, and that's what I show to the patient. Imagine this. So that's what I said to the patient. Imagine that there are 100 men like you, so like Mr. Smith, the same age, the same health status, the same prostate cancer in terms of stage, grade, and PSA. How many patients, how many Mr. Smith will survive or will die from a cancer, from prostate cancer at 10 years? And then you see the tool, you see that after 10 years, if Mr. Smith choose for active surveillance, then 2 men would have died from prostate cancer, but 27 men would have died of other disease. And then when you see at 15 years, you see that 5 men like Mr. Smith would have died from prostate cancer, untreated prostate cancer after 15 years, and 45 men will have died of other disease. So it's important to show this to the patient because it gives an image of the possible situation. And what you have to know is that it was a study of Marianne van Stam. I'm going to talk about it later, but you see that 3% of men have regret about the choice, even with active surveillance. It was about active surveillance. All the treatment have side effects. That what I tell to patient and what we tell to patient as nurses. And for example, the brachytherapy, urinary leak drops in 26%. Well, I'm not going to tell you everything. You can see on the slide. And you see that 4% of patients have regret about the treatment choice. Then the external radiotherapy of the prostate with or without hormonal therapy. Well, you still see urinary leak, so drops for 23%, urinary incontinence for 2%. And don't forget that these patients, if they receive hormonal therapy, they will have the side effect of the hormonal therapy, which is combined with the side effects of the external radiotherapy. And you see again, in this situation, 4% of the patient have regret of the treatment choice. So radical prostatectomy, you see it was a study with the robot prostatectomy. Then you see that drops, urinary leak with drops 60% after 1 year. And urinary incontinence, it means fully incontinent, 4% after 1 year. And also important, erectile dysfunction, 76% of the patient. And then you see 3% of the patient have regret about the treatment choice. And don't forget that this side effect is only for prostatectomy without lymph node dissection. Then if people undergo, patients undergo the pelvic lymph node dissection, don't forget that they could have some side effect of that, like lymphocyte, lymphedema of the pelvic area, abdomen, and legs. And it can be very disturbing for the quality of life. It was a recent research in the USA about the prostate cancer survivor in patients with localized prostate cancer after treatment. And then you see that after 10 years, 100% of patients are surviving. So it's important to remember, because when a patient is treated for prostate cancer, the side effect, it's not sometime for 1 year, 2 years, 4 years, it's sometime for always. For example, for erectile dysfunction. What we see is that well, we have more and more and more robotic prostatectomy, and then you see that it's everything is going better and better. a lot of improvement in technique, and because of the improvement, then the side effects are, I have to say, less major, if my English is good. So you see that an improvement in side effect, for example, in incontinence or in erectile dysfunction. But still, the robot prostatectomy still have a side effect. First, erectile dysfunction. As you saw in the slide, I explained you that 1 year after prostatectomy, 76% of patients has erectile dysfunction. And urinary incontinence, you have to make a difference between drops and fully incontinence, but drops can be disturbing too for the patient. Both drops and fully urinary incontinence, it's 60% of the patient. It's from a study of Marianne van Stam. You have the reference below. So you have to explain to patient when you propose several treatment, and are we able to explain to patient and to give individualized information at this moment? And I have to say, yes, we are able to do it. First, for the erectile function after prostatectomy, we can explain to patient how big is the risk of erectile dysfunction after prostatectomy. How do you do that? You need an MRI MRI of the prostate before, because you can see, well, I'm not a urologist, but I'm going to explain you with my language as nurses. You can see on the MRI where the tumor is, and you can already, or the urologist can already say to the patient, well, for example, on the left side of the prostate, we can spare some nerve, erectile nerve, or on the right side or both sides. And then you see, if you make this prediction, it's published, by the way, you can see the reference below. You can see that, for example, for one patient, because it's, for example, it's Mr. Smith, this, what I'm showing you. For Mr. Smith, the urologist said, well, Mr. Smith, I have good news for you. We can spare all the nerves, the erectile nerves, during the prostatectomy. So it means, and you see below, it's a FP score, so the fascia preservation score you can give to the patient, but you give to the patient the chance of recovering, the chance of preservation of erectile dysfunction after prostatectomy. And if you save, if you spare all the erectile nerves for Mr. Smith, then the chance to have an erectile dysfunction is 8%. On the other hand, it's Mr. I don't know, how can I call him, Mr. Voss, for example. Mr. Voss, you can only spare the nerves on the left side. And in this case, Mr. Voss will have an erectile dysfunction in 72% of the cases. So, for example, for Mr. Smith, it will be another prediction. So we are able to predict the erectile function after prostatectomy already. I don't know if it's used in your hospital. I'm very curious to know that, maybe in the question later. And then the continence, because you know that the patients are always telling us, I don't know if it's the same for you, but that's what I hear every day. Patients are telling us before be treated, well, the erection is not important for me at this moment. It's not really not important, but I don't want to be incontinent. And well, I'm always telling, to the patient, you know, now you say that the erection is not important, but believe me, when you will be you will undergo the prostatectomy a few months after, maybe, or a few weeks after, you will tell me, oh, I regret the surgery because I don't have any erection anymore, and it's important to me. But the continence is important for patient too. And are we able to give an individualized risk of incontinence after the prostatectomy? And again, my answer is yes, we are able to do it. How it's possible? Still, you need the MRI before the prostatectomy. On the MRI, the radiologist need to measure the muscle, the levator ani, and its ILD. It's a little bit complicated, but really, if you work every day, it's not so complicated. And the mule is the membranous urethral length, and then it's easy, I'm not a radiologist, but it's easy to measure on the MRI. And it's with the estimated nerve sparing, the FP score of 0. It means FP score of 0, I forgot to tell you before, but FP score of 0, it means no nerve sparing. And FP score of 12 means that all the nerves will be spared. So the combination of the three variables, as you see here, will give the patient the prediction of continence, of recovering of continence after prostatectomy. And don't forget that the MRI is for one patient, and it will be not the same for the next patient. So it's really for the anatomy of the patient you have in front of you, and not the one that you see after. So we have developed in my hospital a tool that we called CPRED, is a continence prediction score. And this score was the combination of the ILD, the MERL, and the FP scores, also the nerve sparing. And the score is independent of the age, BMI, and surgeon's expertise and comorbidities. And this score provides a percentage of chance of continence recovery within 6 months after prostatectomy. And the higher the CPRED score is, the higher the chance a patient will recover from incontinence. And I have to say that the definition of the continence in our study was no diaper or inlay used, or no involuntary urinal loss. So it means no drops, nothing, really dry, no incontinence. So we divide the CPRED in 3 categories: the high risk of incontinence after CPRED, it's after prostatectomy, a CPRED between 0 and 40% is a high risk of incontinence; intermediate risk of incontinence, a CPRED between 41 and 60%, and the low risk of incontinence, a CPRED between 61 and 100%. The result of the study was well, not really surprising. It's what we had expected, because we checked not only the patient who had the information about the CPRED, but we compared with patients who didn't have the information of CPRED. So it was a retrospective group with the general information. And we had the group with the individualized information about the CPRED. And then we saw that more patients in the individualized information group with prostatectomy as initial preference opted for another treatment when the CPRED was not good, when patient had a high risk of incontinence after prostatectomy. And you see that it's very significant. And we saw that a patient with a high risk of incontinence after prostatectomy choose for external radiotherapy or brachytherapy, and it was also significant. We saw also that patients switched from treatment. So patients who received the individualized information with the 3-PET score, they switch 3 times more often than the one who got the initial the normal information without the secret. So the standardized information, sorry. So you see a big difference, and you see that the secret makes a difference in shared decision making. But the question is, okay, we have an instrument, we have a tool, but does it work? So we checked if the instrument was working, and how did we check? We checked with the use of PETs. 12 months after prostatectomy, well, we checked after 6 months and 12 months, and we saw that the secret correlate with the recovery of continence after prostatectomy. So you can say, okay, it's the use of PETs, it's what the urologist is writing in the file of the patient, but you need the prompts. So the quality of life questionnaire, just to be sure that the patients also answer that the secret is working. So we have it. We send the ISIC short form questionnaire to patients, and then we saw after 6 and 12 months that the secret correlate very strongly with the recovering of continence. So it's a sort of internal validation, and now we need an external validation, of course, but you see that it works. So the information we give to patient is the good information. I have to say, well, it's a good, I don't know if it's a good word, but it's a information, a good prediction, because it works, and you see after 1 year that the prediction is good. So and you see, we saw in this research that men who underwent prostatectomy, that the incontinence as scored in the according to the prompts was negatively correlated with the overall quality of life. So even if patients are losing some drops of urine or fully incontinent, it has an impact on quality of life. So it's important to note that. And it's, well, I don't know if it's funny, but it's, so, well, what we saw is after 6 months, it was affected the overall quality of life, any use of Depper, but after 12 months, not anymore. I suppose that that patients are used to the situation, and then they live with this problem, and that's why it was not more significant, I suppose. So the conclusion that I can give is that compared to standardized information, individualized information makes patients reconsider their initial treatment preference, and individualized information is for sure useful for shared decision making and may impact the quality of life. So that's important, and I hope I was not too long, but now I give the word to Ellen for the following of the presentation, and thank you for your attention.
Thanks so much, Corinne. I will share the second part of the presentation, so hopefully you can see my slides. Okay, so to end, well, after this very nice example from clinical practice that Corinne just shared, we thought it would be useful to give you some basics. If you want to communicate individualized probabilities, how can you do that most effectively so that they can have an impact on a positive impact on decision making? I think it's important to just keep in mind that a key issue with risk communication overall is that the people communicating risks, so clinicians, understand the meaning of this kind of information and also the complexity behind it, but those they're talking to often don't. And it's very difficult to place yourself in the shoes of laymen and try to communicate as clearly as possible. But hopefully with these simple rules, as I've called them for now, it can help you to effectively communicate risks. I haven't included all of the references on my slides because it would be too busy, but this report by the FDA is a nice place to start if you want to get a bit more in depth, because these are very brief and a very quick and dirty overview of how you can communicate risks. And before I get into the rules, I think it's also good for you to realize, I mean, as Corinne depicted, communicating risk and support decision-making can help people make better informed decisions if these risks are communicated clearly. It makes a clinical situation and the choices more tangible. And it can help to weigh things and to really compare options and see what, what you feel is most suitable for you. It's good to keep in mind that educational level has been shown in the literature to not be a good predictor, or age. Basically, most things you can just see don't tend to predict well whether someone is highly numerate, so able to understand numerical information well. In the literature, even highly educated people, clinicians, sometimes struggle with numbers. So you should never assume that because someone is highly educated that they are able to understand the information. So always use the basic principles to communicate clearly. Consider carefully, as clinicians sometimes express some trepidation whether or not they should communicate risks. Really consider, is that based on the patient's wish or their own trepidation about numbers, or is that a more internal aspect? Sometimes what you leave unsaid can also cause fear and anxiety, or keep misunderstandings unresolved, and people are making decisions based on incorrect information. And finally, risk can help. Not everyone is willing or able to cope with that information. It can be emotionally too taxing, so respect your patient's wishes if they desire not to know. And it's important when you ask them to make sure that they are able and willing to hear this type of information. So for these simple steps, first of all, keep it simple. If you want to discuss numbers with your patients, try to avoid using only percentages. Many people struggle to understand what a percentage is. The literature shows that people are better able to understand natural frequencies, so present 10% as 1 in 10, for example. If you want to convey one probability, use the smallest denominator, so not 10 out of 100, but 1 in 10. The bigger the denominator, the harder it is for people to grasp, to really understand, is this a big risk or is this small? I mean, we have 10 fingers, so it's really easy to gauge that. But if you're talking about 15 people out of 1,000, it can be more difficult for people to understand. If you want people to compare, for example, treatment options and their effectiveness, so multiple probabilities are presented, use matching denominators. As well, really be mindful of how you phrase probabilities. So on the slide is an example. You could say, and this seems quite straightforward, I think perhaps, when taking this medicine, you have a 50% chance of experiencing muscle pain. However, this can be interpreted in different ways. So some people might take it to mean that every time you take the medication, you have a 50% chance of experiencing muscle pain. Or others might think that during 50% of the times that you're on the medication, you might suffer some muscle pain. So be very clear and keep it simple, and just be explicit. 1 out of 2 people who take this medication will experience muscle pain. That will help people to understand what you mean. Another strategy that is often used in clinical practice is verbal labels, to give people an indication of the magnitude of the risk without actually mentioning numbers. So a verbal label, just as an example, are things such as, you have a somewhat elevated risk, small chance, etc. But you can use verbal labels, but be aware that there might be a little bit of information lost in translation. So some colleagues looked into this. So if you use a verbal label without giving people the numbers, are you conveying what you intend? Now, this is a very big graph, and we don't need to go into too much detail about it. The key points are On the x-axis, verbal labels that were presented to people are shown. On the y-axis, you can see the number they associated with that label. So everyone was asked, you know, if I say almost never, which probability do you associate with that? So here you can see the circles and the squares show you the median risk that people associated with the verbal label. And you can see here in these bars, you can see the range. So the variability in the numbers that people associated with these labels. I mean, there's much more detail here, but to keep it simple for now, I think what you can notice is that, first of all, there is a lot of variation. So if you say something like, you know, often patients experience X, some people might take that to mean anything from about 8% to somewhere in the region of 80%. So whatever it is you meant to convey, it means something else to the people hearing that information. So misunderstandings can occur, and people might be making decisions based on incorrect information, incorrect assumptions. And we know from a vast body of literature that people tend to overestimate or underestimate risks if they do not know, if they don't have any guidance on, you know, the magnitude of that risk. And it's not only that, but also the perception of risk depends on context. So in the graph I showed you previously, they looked at two scenarios. So the risk of local recurrence and the risk of experiencing nausea. And you can see that for nausea, the numbers associated with the verbal labels are higher overall than the numbers associated with the verbal labels in the context of local recurrence. So it's very important that if you want to communicate verbal labels, you should always add a number to make sure that people are thinking about what you want to convey. Another key point is to avoid communicating relative risks without communicating baseline risks. So, for example, saying to people undergoing treatment X will reduce your risk of developing a recurrence by 50%. So this is a very uninformative sentence, because 50% of 0.1, a recurrence risk of 0.1% is something completely different than 50% reduction of a 60% recurrence risk. So it's really important to give people the baseline risk. And time frame also matters. Are we talking about recurrence risk within a year or within 15 years? Next, it's very important to be specific about the reference group. So who does the point estimate apply to? So people can really gauge, does this apply to me? You know, is this something that is useful for me? And time frame is very important to be very explicit about that, to make sure people understand what you're talking about. It's also very important to describe both the negative and the positive implications. So if you tell people 1 in 4 patients with your characteristics died within 5 years, it's important to also highlight the other side, that however, that also means that 3 out of 4 were still alive, particularly if information, for example, is negative and can be emotionally very difficult to handle. People might not realize that still means that 3 out of 4 people are still alive. And the final point I would like to highlight is that when you want to communicate probabilities, it really helps to accompany that with graphical display. So these are 2 examples, but there are many options in this that you could use. It just helps people by visually seeing it and hearing it. It helps them to understand and make the information more tangible for them. From the literature, icon array, so that's the figure on the right-hand side. These types of figures are really work well and are very accessible to a wide range of people with different backgrounds and levels of numeracy. But people also tend to respond well and understand bar charts as long as you make sure it's simple, not too crowded with information, and you have clear legends. So it's a lot to take in. So here I've summarized it all for you again. If you want to take a look at it, these are the basic principles that will help you to communicate risks if you want to do so, but to do it effectively. Regarding the graphical display formats, it's very good to know that if you're communicating risks and there isn't a tool about a prediction model, for example, there are websites such as iconarray.com. It's freely accessible, and you can just make your own icon arrays to accompany the information you're giving your patients. I just wanted to end with a quote from Victor Montori, a shared decision-making researcher or expert. For shared decision-making, he said, assuming things for patients is neither care nor kind. I think the same goes for risk communication. So let's follow the lead of the patient and make sure that you communicate things clearly. Thank you so much for your attention, and apologies for running late. If you have any questions or comments, we are happy to answer them, or you can get in touch with Corinne or I.
Okay, Ellen and Corinne, thank you very much. We're a little bit over time, but we do have time for some questions. And there's been the question portal is used, so I pick out a few questions to start with for you, I think, Corinne. There's a question about, can the risk of erectile dysfunction or incontinence be predicted on the amount of tumor tissue at the edge of the presentation?
On the tissue, you mean?
The amount of the tumor tissue of the edge of the prostate.
No, it's really based on the MRI and on imaging, and not on the tissue.
Yeah.
So you see where the tumor is on the MRI, and then you can have some prediction. Yes.
Okay. Thank you, John. For you also a question from the portal. Is that what's about the possibility to come to the second or third opinion in the UK, for example, and is it paid from the side of insurance company? Do you know anything about that?
I don't know about, I think insurance companies differ. I have to say, while I had multiple second opinions, I didn't pay for any of them. I used an networking to make contact. I got phone numbers, email addresses, went to see people in their offices. It was, who I knew. I was fortunate in that way, but I was also spending a lot of time researching it because I'm a biologist by training, and I just went away for 4 months and tried to get as much into my head about prostate cancer as I could.
Thank you. So I heard you now of your private life and what's helped you to make decision. And in your presentation, you talked also about professionals. I didn't hear that much, if I'm well, about the role of a nurse in your case or broad. Can you tell something about that?
Sadly, in terms of my initial treatment, the nurse didn't actually come into it. Things have improved somewhat since over the last 20 years. We now have dedicated urology nurses, and I don't think people would put up with what we put up with 20 years ago. So the nurse, in my experience talking to patients in peer-to-peer situations and conferences, the nurse is the person that they regard as the key, because the nurse will give them more time and will explain things in a way that the specialist tends not to.
Okay, thank you. That leads also a little bit to you, Corinne. You talked about regret, and is it possible how it could be otherwise to downsize the regret?
Well, as you saw, the regret is between 3% and 4% of the patient, but it's too much. Mm-hmm. Even 3-4%. You know what I was thinking, because I'm preparing a PhD, and what I was thinking, because we give now the prediction tool, the CPRED, the risk of incontinence after prostatectomy, and it would be nice just to make a research about the regret in this patient.
Mhm.
Do they still have regret after individualized information? That will be very interesting to see that, because the regret that we saw in previous studies is based on general information that patient received. So I'm curious to see if they still have regrets after the individual prediction.
And is there something said about the influence of the nurse or the clinical nurse specialist in figures of regret?
No, it's not. But in the study of Marianne van Stam, we saw that one of the results was very interesting, because patients mentioned the role of the nurse and the nurse practitioner in the Netherlands. We have a role, and the conclusion of the study of Marianne was that the one who the best information gave to patient, but the patient was happy with the information, was the nurse practitioner and the radiotherapist. And
Okay.
I'm sorry, but not the urologist.
Yeah, thank you. For me, I have a final question. In the portal, there's no questions left. It's for you, Ellen. You gave us a lot of numbers and insight and tools and how to use those tools. I missed a little bit the role of the partner, the spouse. Can you tell us about it? What's their kind of role in shared decision making for her patients, his patient partner, his patient partner?
Yeah, so yes, I didn't explicitly touch on that. So that's a very good question indeed. Well, I think when I talk about patients, you can draw that broader to their whole, their partner and perhaps other significant others in their family. So what we hear in research often is, the patient is the focus of the consultation, but then they go home and, if they have, for example, a decision aid, that can help them to communicate with their partner, with their children, if they weren't able to attend the consultation, to include them and to get their opinion. And that also helps patients to make decisions, often is what we get back from patients. But in the consultation itself, I mean, I would see the partner as also part of the consultation, and to include, include them as much as possible in that aspect, especially when you're talking about prostate cancer. Of course, it also affects the partner, the different side effects that people can develop from the treatment options. So yeah, so I would draw it a bit broader than I'm speaking about patients, but yeah.
Yeah, thank you. We all know, I think, that it's a system, the patient with his partner and family. John, would you like something to say?
You have you have time for a very short anecdote?
I think
on that
you
issue.
get to the last minutes of this evening.
I remember a patient told me that he had determined on having a prostatectomy on the basis that his wife said to him, why not go for that? You'll only be a few days in hospital and then you'll be out, as opposed to having to go through 35 separate visits to the hospital for your radiation therapy. And then when he when he came out of hospital, he discovered that it took him a lot longer than 35 days to recover continence.
Indeed, yes. Okay. Corinne, Ellen, John, thank you very much for your insight of your whole perspective kind of research, patient and clinical care. And also all the participants. There are some left already, but there were 70 participants would join in. So thank you very much. And the EAUN for organize this webinar. And have a very nice evening.
And Maarten, I would like to thank the Sick Prostate for their work for this program. Thank you very much.
Yes, indeed.
Thank you very much.
Yep.
Good evening.
Bye-bye.
Bye-bye.